Good evening, everyone. Today, we have a great panel discussion on early gastroesophageal cancer. And for the discussion, we have some of the big name to start with. Dr. T.S. Rao, sir, a very legendary surgeon and a great teacher. Dr. Squamous, sir, Dr. Dhaval Bhai, Dr. Archit Pandit, Dr. Pooja, Dr. Nandita, and Dr. Mangesh. Before I start my panel discussion, I have this statement, and I want my panelists to just give their remark or their comment, whether it's true or myth. To start with, medical oncologist Dr. Mangesh.
Thank you for the question, Dr. Devendra. So first thing is a little bit of a disclosure here. My internet connection is not good. So in case if you ask me any other question in future and I'm not
Perfect, I'll move.
Not able to respond immediately, please proceed because I don't know. Yeah. So the management of esophagus and adenocarcinoma, esophagus G junction are two different diseases and shall be treated accordingly. I think with the recent data, I am actually confused, to be honest, but every center has got their own protocol. Basically, it is as per the the comfort of the multidisciplinary team, the radiation oncologist, the surgical oncologist, the medical oncologist. In many cases, since we know the curative therapy is offered by the surgical oncologist and to a great extent by the radiation oncologist, we are happy to play the supporting role on this. I still don't believe that there is one size that fits all for this question. Okay. But if
so
I had to go,
I can put another option of evolving, true, myth, or evolving. So you can choose either of three.
I would probably say evolving in many ways.
Perfect.
Because that would probably be
my radiation oncologist, Dr. Nandita and Dr. Pooja.
I would say there is a difference between the two.
Okay, so according to you, this statement is a true?
Yes.
Dr. Pooja?
Based on the evidence so far.
So I have a different opinion. Being a radiation oncologist, I would say that the squamous cell carcinomas, they tend to behave much better. They have a good radiation response. So I think the evolving would be a better way to say that, because we still don't have many well-powered trials to comment. But yes, the squamous cell carcinomas, they behave much better than the adenocarcinomas as far as the radiation response is concerned.
Okay. Dr. Archit?
I would say evolving.
Evolving. So I should have put evolving in my slide only. Dr. Dhaval? And Rao, sir? Sir, your mic is mute.
I would say it's true.
Okay.
Epidemiologically, they are different. When metastatic, they behave differently. When you operate, they behave differently. And then I think future is going to offer split them completely and then treat them differently. That's my opinion about these two.
Okay. Dhaval bhai, you missed the answer.
Yeah.
If you are there.
Yeah. Yes, please.
Okay. So true, myth, or evolving?
I would say true only.
Okay, perfect. So half of my panel says this is a true statement. Going forward with this in mind, let us come to our first case. It's a 52-year male, fit gentleman with recent history of dysphagia to solid, well-maintained performance status. Endoscopy says 25 centimeter from incisor, there is ulcerative lesion, which is non-obstructed. Biopsy turned out moderately differentiated squamous cell carcinoma. On imaging, there is around 38 millimeter segment of 12 mm thickness with some thread stranding. There are a couple of basins which are showing lymph nodes, largest 13 by 16 mm. This is the imaging finding. If you can see here, this is the normal non-dilated esophagus, and here there is thickened esophagus. Right behind the trachea, if we see the cuts, it is in the thoracic esophagus behind the trachea. So with this image in mind, I would like to ask Dhaval bhai, can you classify the esophageal cancer based on the tumor location?
Okay, so there is two ways that we can classify. One is upper third, middle third, and lower third esophagus. And another is cervical esophagus, thoracic esophagus, abdominal esophagus. And in thoracic, we can divide it into three parts according to AJCC. According to AJCC, it is up to 18 is cervical, 18 to 24 is upper third, 24 to 32 is middle third, and 32 to 40 is lower third thoracic esophagus.
Okay.
And while clinically it is up to aortic arch and then pulmonary vein and diaphragm.
Perfect. So looking at this picture, what is your impression?
So this is the middle third esophagus.
Okay. Anyone in my panel would disagree with this finding? To put it as middle third squamous cell carcinoma of esophagus?
I think according to the latest AJCC, it's 15 to 20 centimeters cervical, and then the thoracic is divided into three parts: 20 to 25, 25 to 30, 35 to 40, and then beyond that is abdominal esophagus.
Acceptable. So here our disease is starting from 25 centimeters,
25.
madam.
So kind of between upper and middle thoracic esophagus. You generally call it as
Junction of upper mid. So I'll put it as upper mid thoracic esophagus.
Yeah.
Will that be fine?
yes.
Devendra,
Okay.
I think what becomes important is what it is related to. You talk about tracheal bifurcation as the cutoff between the upper and the middle third, but here it seems to be abutting the trachea and not the carena.
Right, sir.
So effectively, in terms of your treatment planning or the precautions that you take, it is a bit into the upper third also.
Right, sir.
Yes.
Perfect. So rather than considering it as middle third, it's upper middle esophageal
Upper
cancer.
middle third, correct.
Yes. Dr. Archit, I have a question for you. Do you have any particular number in mind when we talk about endoscopic findings like 21 centimeter, 22 centimeter, 23 or 24 to take a decision whether to keep that patient for later on surgery or to think of keeping surgery as a last and salvage option?
Right, that's a very good question, Dr. Parikh, because a lot of controversies roam around the level of growth based on the endoscopic findings. However, I totally agree with Dr. Rao sir that it is the surrounding structures that will dictate whether I would like to, go for what kind of a treatment. However, the number that you asked, it's generally 21 to 22 centimeters. Anything below that may fall to be a resectable candidate, maybe neoadjuvant treatment, and then, but anything above that, above 22 cent, that is where the aortic arch lies. So anything up at or above the aortic arch would fall into an upper, and so I think that is what you are trying to ask.
Agree. Yes. So when we are seeing that number 21 or 22 centimeter, then we have to be very careful and seeing the radiological finding also, because with the height of the patient, disease level will become slightly upper or lower. So in a very long patient, 21 centimeter may be at the inlet, but in a short stature patient, 21 centimeter will be at mid behind the carina. So that is also to be kept in mind. So number
Absolutely.
is not the only thing. So endoscopic finding along with radiological finding, both has to be considered when we are planning these cases. With this finding in mind, Dr. Mangesh, what will be the plan for this patient if you are seeing this patient in your consulting room? I guess Dr. Mangesh is not able to answer. So I'll come to Dr. Nandita. Madam.
So for this patient, like all cases, we should have a multidisciplinary discussion with the surgeon.
Again, I lost your question because of patchy internet.
Sir, what will be the plan for this patient? If this patient visits you, I guess Dr. Nandita, you should answer.
Should I go on? Okay. So like I was saying, this would involve a multidisciplinary discussion. The surgeon, the radiation, and the medical oncologist have to be involved. Though our institute and myself, they were serious proponents of the cross protocol, a lot of patients would fit into the cross trial protocol. However, two issues with this patient. One thing is, based on your description of the lymph nodes, it looks like he has at least N2 disease, if not more. And these patients would not fall into the eligibility criteria of the cross protocol. The second issue is whether the surgeon is going to be able to remove the entire pre-treatment extent of the disease. And again, the issue is with the supraclav lymph node. As far as my knowledge goes, supraclavicular dissection is not a regular part of a two-field esophagectomy. So in this patient, I would give him a radical dose of radiotherapy and chemotherapy, but keep him on close follow-up for early salvage.
Okay, so what will be the dose?
50.4 gray in 28 fractions with concurrent chemotherapy with weekly Paclitaxel carbo.
Okay, Dr. Pooja, what will be your opinion?
So I think apart from all the cervical esophagus lesions, all the rest of all the esophagus lesions should be first of all decided at the multidisciplinary tumor board regarding the operability based on both the medical and the surgical grounds. And if it is operable for this patient, I would definitely go for a neoadjuvant chemoradiation, then followed by surgery.
Okay, so now that is very great.
So you got the controversy already.
No, so you have created the controversy, and I'm happy to see the controversy. So I'll ask. So Dr. Nandita, I have a question for you.
Yeah.
Why you choose definitive CTRT versus neoadjuvant chemoradiation? Only on the basis of lymph node extent, or anything else also to keep in mind?
Particularly on lymph node extent. Most of our data of neoadjuvant CTRT is based on the cross trial, and this patient would not have been eligible in the cross trial because he's locally advanced, and that would entirely be based on the number of lymph nodes as well as the location of lymph nodes in the supraclav. And in general, neoadjuvant treatment should be instituted when the surgeon is going to remove the entire extent of the pre-treatment.
Perfect. So let us ask.
That goes to the surgeon.
Surgeon, Dr. T.S. Rao, sir. He is also based in Hyderabad. Yeah. Sir, how confident you will be to subjecting this patient to neoadjuvant treatment with the surgical setup in mind that you will be achieve R0 resection later on?
Devendra, although you've been smartly blaming the panelists for the controversy, you have created a case capsule to induce a controversy. And because the neck node is 6 millimeters.
Correct.
So that's what really counts. Anything that small can be anything. So both the panelists, both the radiation oncologists actually are correct. Definitive CTRT is definitely a good treatment for two reasons. One is, if you think the neck node is positive, if it actually turns out to be positive, I would actually move towards definitive CTRT. And then there is tracheal abutment. That's where it can become difficult. If it is below the carina or at carina, surgery would definitely be there, despite the node. But otherwise, with the tracheal abutment, significant abutment, it can be a difficult procedure later on, unless there is a explicit response to the radiation therapy. So both are good options. If you can prove or disprove what the neck node is, then I think it will make things clear.
Okay, perfect. Coming back to radiation oncologist, what type of
is it the neck node that is going to dictate the treatment protocol? Because the neck node will still make it locally advanced. It will not make it metastatic.
So loco-regional, to put it in Dr. Archit Pandit's.
Exactly. So that will still be loco-regional, right?
Correct.
Yep.
Still, it becomes operable. You can definitely do a lymph node.
Yep. So as sir said, both the options are equipoised. So we cannot rule out definitive CTRT that because that is also practiced at many places. And at the same time,
Dr. Devendra, can I ask a question to Dr. Rao, sir?
Yeah, please.
So if at the TBD we decide that this patient seems to be operable, then what is the better option to go forward for?
I would review after radiation therapy, and I would prefer to operate.
Yeah.
Yes.
So I think we have some evidence which says that for better local control, for better progression-free survival, surgery should be the treatment of choice, at least for the non-cervical esophagus lesions. And when the node is such multiple, I think it needs better, more local control. And that is why I think tri-modality therapy would work more better for this patient.
And Dr. Pooja, what will be your preference amongst 3D CRT, IMRT, and ITRT?
So when we are in today the era of the conformal therapy, of course, a minimum 3D CRT should be the ideal way to go forward. But when we have the other advantages with the more advanced technologies like IMRT, it is very much better because we can decrease the dose to the heart and lungs. So anything between 3D CRT and IMRT would be fine for this patient. IGRT would be like icing on a cake. It is not very much required. It will be adding some cost to the patient's treatment design also. So I think anything between 3D CRT and IMRT would be good enough.
And as you are giving neoadjuvant chemo radiation, what will be your dose?
So if you're going for a neoadjuvant chemo radiation, I think 41.4 gray would be the dose I would like to go forward for.
Any experience of extended cross protocol? Any of my radiation oncologists, if you are planning neoadjuvant chemo radiotherapy, anyone believes in extended cross protocol giving 45 grays?
It's kind of in between a radical and a neoadjuvant dose. Honestly, I don't know. We should really ask the surgeons whether there's a huge difference in the operative morbidity between 41 and 3.4.
Devendra, I don't know if surgeon can answer this, but we have been analyzing our patients and we were shocked actually, although we really follow our patients very closely and then keep talking to them. The dropout rate after cross protocol or any other preoperative treatment, neoadjuvant chemotherapy or radiation. We do neoadjuvant chemo radiation for all squamous. The dropout rate is very high when the dysphagia is relieved. So there are a group of radiation oncologists here who do 50 instead of 40.
Okay.
Because even if the patient drops out, you would have given a significant
kind of definitive dose. So correct. In a way, patient is adequately treated.
And regarding morbidity, we've been watching our videos, reviewing our videos. The reaction, the morbidity does not seem to be significant enough to make it difficult for us or for the patient.
True, sir. So
not much of morbidity.
So 41 or 45 will not make any difference to answer the question. Yes, absolutely. We welcome Dr. Squamous sir as well. He has just joined the panel.
I've been missing Squamous till now.
Yep. So when Dr. Pooja, when will you first do the response evaluation? I am putting three options: mid-cycle when you are giving chemoradiotherapy, at the end of your chemoradiotherapy, and at conventional point where actually surgeons try and evaluate the patient, 4 to 6 weeks.
So ideally is the conventional one, that is the 6 weeks after the chemo radiation. But having said that, we radiation oncologists also believe in doing an interim analysis for the reason that we try to understand what's the biology of the disease and what is the response. That does not, however, change our radiation volumes or dose, but yes, that really helps us to understand, and then of course to sometimes also convince the patient also that he's doing well. So probably something around, if you're doing 41.4 in 23 fractions, then probably something around the 3rd week of chemo radiation, I would like to go for a response evaluation scan.
Perfect. And any temptation to go for definitive CTRT if patient is responding well?
So if at the first tumor board, we have decided that he is operable and we are going to operate, so I think it is fair enough to just conclude at the 41.4 and not convert them into definitive.
So stuck to the plan, what you have planned.
Yes,
so this
absolutely.
Patient has received 41.4 gray. We usually stop at 41.4 gray. Patient tolerated the therapy nicely, received 5 cycles of paclicarbo, and this was the finding. Dr. Archit Pandit, looking at this scan, have you any doubt of operability? Bigger size picture is post therapy scan.
So, Dr. Devendra, I think you have very smartly chosen the level of the growth. I think an interim analysis, early response assessment is what we do with our radiation colleagues. for such patients in whom the growth is abutting with trachea, and that is when we try to assess the response around 3 weeks, as rightly said by ma'am. So I think this has responded pretty well, and till the bulk of the disease, which was almost at the level of carcinoma and little bit above that, maybe a couple of or 3 sections above that. So I think we would go with surgery as our plan. However, I would like to do a bronchoscopy and see the mobility of the posterior wall of trachea on bronchoscopy. Also, I would like to do the bronchoscopy in the initial phase before
planning treatment. Before planning treatment, absolutely.
Yes, because this has actually helped us a lot. If the posterior, in our experience, if the posterior wall of the trachea is moving along with the respiration, relatively we have found the planes very, very clear.
Right. Okay.
Also, the location of disease, whether the location of the disease was anterior in the anterior wall of the esophagus or the posterior wall of the esophagus, will also help you in assessing whether to go ahead with a radical surgery.
Absolutely. So, Dr. Somesh sir, whenever such patients comes to us, as a surgeon, what is the biggest challenge for us? Whether non-compliance, as Dr. Rao sir rightly said, most of the patients fall out because of becoming asymptomatic, or because of CTRT related morbidity, or because of higher difficulties in performing such surgery, or because of post-surgery complication. What are the biggest challenge for a surgeon?
Well, obviously, all of them are challenges. See, these are patients who have already lost a fair amount of weight before therapy is started, and some patients may not regain that weight. So the nutritional status, the pulmonary function of these patients is very important. So this interval, if you are planning for a combined modality treatment with preoperative chemoradiation, what I would do is I would use this waiting period of 5 to 7 weeks post-radiation to rebuild the nutritional status and the pulmonary function of the patients. So that would utilize that entire period for rehabilitation of the patient. If we do that, all our patients, yes, they go for chemoradiation. We have not found, and that is supported by the literature as well, that the morbidity is prohibitively high for these patients, even when we are taking patients beyond the cross-bottom criteria. Because in clinical practice, you do take up N2 disease, T3, N2, and those kinds of disease. In the long term, they may not fare that well, but in the short term, the morbidity is not too bad compared to upfront surgery.
Right. So, what is the correct interval for taking this patient for surgery post CTRT, Somesh sir?
Dr. Devendra, if I can add one thing, I think one of the major concerns in that case, in this case, would be anastomotic leaks, because radiation dose is also going to go into the neck, and the upper esophagus is also going to be exposed to a certain extent to radiation therapy.
So I would like to, yes, please.
Yeah,
Yes.
so anastomotic leaks are a major concern, and of course the surgeon has to, do something to tackle that, which we can elaborate when we are going to discuss that.
Devendra, can I make a comment?
Yes, Samir, please.
Yeah, so in fact, this was a question to my radiation colleagues also, and as Dr. Archit pointed out very nicely. So any of my radiation colleague is practicing fundus sparing radiation in esophagus to avoid these leaks, because there's a study which has suggested that by avoiding radiation to fundus, probably these leaks can be, the risk can be reduced. So any of my radiation colleague, whether I am not practicing it practically, and we have not seen that much impact. But what about others? What is your experience?
For the mid-thoracic esophagus, there's not going to be any dose to the fundus, so I don't see it being a problem in this case.
Maybe for the lower part.
Maybe for the GE junction.
Yes. Yeah.
Okay.
So are you practicing fundus sparing?
No, not really. No. I mean, if the tumor is really close, you can't really spare it. And if it's far, then you don't really need to spare it. So
what about
I don't
adaptive
really
radiation? Are you practicing adaptive radiation in esophagus as well?
Not in esophagus, no.
Okay, thank you.
If I may make a point, make a comment on this issue raised by Samir. It is our experience that we've had possibly related to radiation of that the stomach, a higher incidence of post-operative long-term strictures in absence of leaks. We do objectively test for leaks. We have not encountered a higher leak rate, but I would tend to ascribe a higher incidence of strictures to radiation.
Okay. So much. Do you staple or do you hand sew?
No, my techniques are the same. I was always doing a hand sew. I understand that stapler is a larger anastomosis, but if because the technique remains the same, so and if I see a higher incidence of stricture, I would ascribe it to different causes.
Sir, may I ask a question, Rao sir?
Yeah.
Will you be able to do a stapled anastomosis in this case?
I would do it, but I would do a semi-mechanical, not a total mechanical. I would still do it because I'd keep the esophagus very short and do a side to side 2 or 2.5 centimeters anastomosis and then bring it like a lid and anastomosis. It won't be a
you can
total
always
mechanical.
do circular anastomosis as well, sir. Yes, that is also
Circular is something that we try. Circular is something that I don't like.
Okay.
It's the same anastomosis, but a semi-mechanical anastomosis.
Okay.
Yeah.
Devendra, can I ask a question?
Yes, please.
So, Somesh sir, there was a question by Dr. Devendra a few minutes before where he was trying to ask that whether we can go for an extended cross protocol. So I would like to ask this question to you as a radiation person, that would you be happy that if we radiate up, say up to 50 gray, would it really have any added advantage in the response, in the resectability part for you as a surgeon? And secondly, when we are talking about so many complications like leaks and strictures, do you think adding more dose from 41.4 to 50 would add more of these complications also?
So I am asking the question, but I am happy to answer this question. That as a surgeon, my personal choice is 41.4 gray, but we have seen a lot of patients who have received 50 grays and they have come to us. And I guess apart from dose, another important thing is the interval. If duration is within 6 weeks, between 6 to 8 weeks, then I will be happy to operate. And most of those patients will have a very similar picture. So 41.4 or 45 or maybe 50 gray. If that patient is been operated at 6 weeks, probably they will behave same. That is my personal opinion. Rao sir or
correct. I fully endorse that, Devendra. See, what we see in rectum is much higher dosage. But as long as you operate between 6 and 12 there is no problem at all. You don't get into bladder, you don't get into prostate. Extrapolating rectum here, although we don't give 55 and all here, I think it's the duration at which you operate. Because what happens is when these patients, the evidence comes from patients who are not compliant. They come after 6 months due to COVID or even otherwise. That is when even 40 gray makes your life difficult.
Yeah.
So it's not the dose alone, it's duration that Devendra brought out, which is extremely important. 50 gray doesn't hurt. 50 gray doesn't hurt. It's the duration that hurts. So the radiation oncologist is not to be blamed.
Yes,
so that was I was trying to understand, that whether we should convey this message, that whether extended cross protocol would really help in terms of any added advantage.
So if you are planning surgery, it actually does not help.
Exactly.
There is another evidence which says that anything more than 55 grays actually hurt the surgeon during surgery. So now NCCN rightly limit the dose even when we are giving definitive CRT. We should limit 50 gray, but sometime when it is situated higher up at the inlet, then they mix up with the neck doses. They try and give up to 60 gray. So, and if that patient needs surgery, then it will be a real challenge. So
true, agreed.
Basically, when the cervical esophagus is going into upper thoracic, we try to, we tend to mix the doses. So this is the situation.
So for cervical, it is okay, but for upper thoracic, where actually surgery may come, then it becomes problem if you have given 60 grays.
See, the morbidity, Devendra, is while you are dissecting, the difficulty, and then if the neck esophagus is not irradiated and the fundus is not irradiated to a large dose, the anastomotic morbidity that Soma is brought out is also very important. So during dissection, you may get away, but if you have irradiated the neck and the fundus to beyond 50, I think leak rate should be higher. And once it leaks, stricture rate also will be higher.
I'm happy to see all my surgeons are doing MIS. So I'll be happily ask this question: approach, open versus MIE. Double by Somesh sir, Rao sir, anyone, please.
Obviously, MI, minimal invasive approach, would be the best suited for. I would rather say the care has been transformed because of the minimal invasive approach, not only in terms of post-operative recovery, but even in terms of long-term outcomes also.
Okay. Somesh sir, if I may ask, thoracoleproscopy versus robotic, what will be your preference?
Personally, the thoracic part, I prefer to do robotically, and the gastric mobilization is done laparoscopically in our case.
Okay. Rao sir?
I do both thoracoscopy with both laparoscopy and robotic. There are advantages of both. Robotic is a little more easier in the supraesophagus compartment. In infraesophagus, it doesn't make any difference. I think what Soma is told in the abdomen, I think laparoscopy is much better.
Much faster.
Much better. On every count, it is much better.
Dr. Archit, what type of lymph node dissection you will try and do? 2-field versus 3-field?
So I would do a 3-field dissection, an extended 2-field, and also send the extended 2-field nodes for frozen, and subsequently perform a 3-field lymph nodal dissection. Provided, because you said that the supraclav nodes were
right supraclav.
Yeah. Archit, I think this patient, if you have accepted that it is not positive, then I think you should do a 3-field.
Absolutely.
This is one of those patients who deserve a 3-field.
Absolutely.
Yeah.
Dr. Archit, in your experience, which nerve is at higher risk, left versus right? In your personal experience.
The right one.
The right one.
The right recurrent laryngeal nerve. The right recurrent laryngeal nerves are the ones which are the primary draining site. In my experience, I have always found them, and even in certain cases, the recurrence pattern is also suggestive of having the right recurrent laryngeal node coming as positive.
Okay, and in terms of nerve palsy, which recurrent nerve is at a higher risk when we are doing 3-field lymph node dissection? Personal experience?
I don't have, honestly, I've never had a nerve palsy. I've never injured a node. I know it is such a statement to say never and no's and always are not part of oncology, but I've never had a recurrent laryngeal nerve injury.
But the way you do your surgery, we will accept that statement. Rao sir, as you are working in an institute, in your institute, what was your experience?
We do have paresis and paralysis, but I don't know. I cannot quote which side was more, to be very honest.
So if I may answer this, at my center, left side is much more common. In fact, most of our palsies are left-sided. Most of them were temporary, but I don't know whether
it's a little more difficult to do the left side. There's no doubt about it. But palsies, I don't remember.
I would say, Devendra, that might not be related to the lymph node dissection, but maybe to some maneuvers during the dissection and anastomosis.
Absolutely.
Right. We also used, Dr. Devendra, this is a little out of the context, but we also use IONMs. So intraoperative nerve monitoring, which actually help us in, sometimes when you do a recurrent laryngeal nerve dissection, the nerve bifurcates, and then you are really in a fix whether this is going to the esophagus or it is going ahead and going into the voice box. So So we are routinely doing IONMs, and it has really helped us a lot.
Okay. Preferred instrument, hook versus harmonic versus ligature when you are doing three-field supremediastinal node dissection.
Ligature for me.
Archit, Dholbhai, all
I would say I would like to have luxury of all and then choose, but obviously ligature around the nerves, no doubt.
At the point of recurrent laryngeal nerve dissection, the supraazygous part, I use scissors and bipolar. I don't use any of them. No hook, no.
So, sir.
Yeah, scissors and bipolar for the entire thoracic part. Two instruments.
Okay. Role of frozen section in this particular case for upper margin, evaluation of upper margin.
Dr. Devendra, 4 minutes left.
Okay.
Yeah, this case definitely deserves frozen section for proximal margin, no doubt.
Okay. And what exact margin you will be looking at, Dholbhai? 1 centimeter, 2 centimeter?
5 centimeter, 5 centimeter.
Proximal margin, I am saying.
Proximal 5 centimeter I would target. No doubt negative margin would be the ultimate goal, but I would wish that I get 5 centimeter margin, proximal margin.
Okay, perfect. So we try and achieve at least 1 centimeter to 2 centimeters. To coming back to medical oncologists, this slide is now putting all these patients at a risk of further treatment. So this particular patient had PT1N0. We also had done 3-field lymph node dissection, and he had T1N0. So would you like to offer this patient nivolumab? Doctor?
Yeah, hopefully I am audible now. I've had serious internet issues. So yes, there is data from a very good phase 3 trial of nivolumab, which the trial name is Checkpoint 577. It has been shown that in those patients where we don't achieve a pathological response, complete response, the chance of recurrence is as high as 70%.
So what is your experience?
I am using it for one patient currently in the adjuvant setting, but I don't have the duration that is required for me to comment whether it actually has helped to prevent the recurrence or recurrent metastasis. So probably I'll have to wait for some time to answer this, maybe a year or two later. But with the data that is being presented on that phase 3 trial, it looks very promising, because we are all aware of the fact that irrespective of the best treatment that we provide to our patients, there is a very significant chance of recurrence of the tumor, and many a times the tumor may not even be resectable, or even there is no other salvage therapy that could even be offered. So I would definitely try a few of my patients on this regimen, adjuvant nivolumab, those who are affording, so that we can actually see whether in the real world scenario it is helping our patients or not.
Okay. I have a question for Rao sir. Sir, as a surgeon, we have a dilemma of explaining this thing upfront before starting any treatment, or to wait till the final histopathology report and then disclose. And if we do that, then patient will be in surprise mode that no one has said this. So sir, how shall we proceed?
Explain what, whether you'll achieve RCM or not.
This particular slide to our patient. So this particular treatment modality that you might need this treatment.
I don't know. I have the luxury of 12 medical oncologists. They do this job for me.
Yes,
I don't know. It would be difficult. I accept that it would not be easy to talk to each patient like this. But you might eventually end up with this. It's true that you can end up with this.
Right. So Dr. Parikh, I think this Checkmate 577 has just come out of the blue. I'm so surprised that people have not tried adjuvant chemo and they have just straight away come to nivolumab. I would say just take this data with a pinch of salt. No offense to any of our medical oncologists, and I totally agree with this. This is an 800 patient data, so it's not a small data. It is a significant data. But if you dissect it, if you see the median disease-free survival, the control arm was having 11 months. does any of the surgeons over here have their disease-free survival, disease-free interval 11 months? You know, even if they were not. So if your control arm is so bad, you give nivolumab, you give I mean, I'm not discouraging the study, but I think we should wait and watch.
We are seeing much longer DFS, even when
so
there
if
is
you
no
if
CR.
you are seeing longer DFS, probably the benefit of nivolumab will not exist. So in this study, the disease-free survival was, median disease-free survival was 11 months, and compared to nivolumab, which increased to, I think, 22 or 23 months or something like that. So apart from this, just one small comment. I think exactly the same case we also tackled in our practice. And just a food for thought for all the surgeons. What we did was to bring the conduit, the stomach conduit up into the neck. We used the retrosternal approach, not just the posterior mediastinal. Because of the chances of leak were so high, we wanted to isolate the posterior mediastinum so that the chances of mediastinitis is less, and bring the conduit through the retrosternal, because that is what I've seen a lot of Japanese surgeons doing very frequently, taking the retrosternal approach and bringing the neck, the stomach up in the neck, so that even if the leaks happen, the patient is not at risk.
Absolutely.
Dr. Devendra, can you
this
please
will be my
conclude?
last slide. If I may, quick comment from my surgical colleague regarding salvage esophagectomy, extent of node dissection, and role of MIS. All four.
We have done quite a few. Devendra, we have done quite a few salvage esophagectomies. We're close to 20 now, in the past 20 years, obviously. We don't do the supraesophageal resection. The recurrent laryngeal nerves is something that I leave behind.
Right.
Infraesophageal resection is done. And surprisingly, these patients have actually immediate post-op, or the 30-day mortality was nil. So the difficult dissection, you keep on chipping slowly. Thoracic part, the longest procedure was about 4 hours. Difficult, but it is achievable.
And all MIS or select?
No, initially while I was in MNJ, the first 4 were open. The rest of them are minimal access.
If we have to look at the last 3 years,
it's all minimal access. I didn't do a robotic, so I'm not as good in robotic as in laparoscopy. So for salvage, I've been preferring thoracoscopy.
So no conversion, sir?
No conversion at all. No. No, our conversion rates as such is practically nil. So, things can become inoperable, but conversion is practically nil.
True, sir. Dhawal bhai, any last comment?
So I have had one very bad case where the lung was so badly, the pleural adhesions were so bad that I had to convert. I have done total 3, and 1 I had to convert because of very bad pleural adhesions. That there was no way that I can get around, and I had air leak also post-operatively in that particular patient. So difficult but achievable, yes.
So
Nothing wrong, Dhawal. I'm actually waiting to see some patient like that, maybe. Yes.
if I may add a couple of points. So if it is a post-definitive radiation or chemoradiation salvage and retrotracheal disease, I would be a little wary of doing it minimally invasive, because the tracheal dissection becomes very difficult. And in those patients, I would prefer to do this. So these are all retrotracheal upper third esophagus. I would do an open dissection in those cases. For all infracarinal, the salvage is also minimally invasive. For retrotracheal disease, like Dr. Archit said, we also do a retrosternal stomach pull-up, not in the posterior mediastinum.
Okay, it's been a wonderful session, and I thank all my panelists. Thank you very much, and I say sorry for overtiming my